Good evening, good evening, good evening, everyone. My name is Robert Motley. I'm an assistant professor at the Boston College School of Social Work, and I'm also the founder of the Racism-Based Violence, Injury, and Prevention Lab. I want to welcome you all here today for our second day of our three-day event, which is entitled Empowering Wellness, A Journey Through Mental and Physical Health in Black and Brown Communities. For today's event, it's entitled Promoting Physical Health in Black and Brown Men, which will be a panel discussion. This comprehensive event will feature a panel discussion to address key aspects of physical health care for Black and Brown men. Some of the things that will be discussed will be preventative health measures, the impact of social determinants on health, enhancing healthcare access and quality, and the importance of cultural competence in medical care. And so once we're done, there will also be time for a Q&A from the audience. And at the convening of the event, there will be some food out in the lobby for all attendees. And also, we have a camera set up in the back right there. So we would love to have about 5 to 6 of you all just to give us a quick, what was one key thing that you felt you learned or you enjoyed the most about the discussion from this event? So if you wouldn't mind, 5 or 6 of you all will come. It's just 15 seconds to let us know one good thing about the event or some key takeaway that you found that was most important from you attending the event. All right, so what I want to do now, I want to introduce the moderator for today, James Jimmy Hills, who's a prominent community advocate, self-made talk show host, and critical voice in the Boston media landscape. Throughout his 40-year career, James has mastered community building and relations by serving in leadership positions in several Boston-based nonprofits and all 3 levels of government. And a lot of folks around here know him for his podcast, Java with Jimmy. So can we give a warm welcome for James Hills?
Good evening, everyone. As I want to say Dr. Motley just said, my name is James Jimmy Hills. I'm the host of a community-based platform called Java with Jimmy. Just a little bit about me before I bring my guest on stage. In 2020, Governor Baker said we need to stay home on March 23rd, on March 24th, coming up on 4 years this Sunday. I got my coffee off of Keurig and went and sat in front of my iPhone, went live, and community members came in on the way up here. My manager and I was looking at a question my mom asked me during that live, and she said, will this be an everyday coffee hour? And I'm like, no. And at that time, we thought COVID was gonna be, 2 months, we'd be on lockdown, a couple of weeks maybe. And 4 years later, we're still here as an impactful platform. And so I'm gonna be honest with you all. Running up them stairs and trying to talk right away didn't warm me out. So just give me 2 seconds to catch my breath real quick. I'm also very real and authentic. And so in the past 4 years, we've had the opportunity to partner with a lot of health entities, Massachusetts General Hospital, the Department of Public Health, the Boston Public Health Commission, and we have a segment called Your Healthy Java. The name of my show is called Java with Jimmy. And we talk about health equity. We were very instrumental in getting vaccination information out and making sure that the proper information was in Black and Brown communities during COVID and beyond. And so that's now morphed into bringing people on to get the correct information and talk about health equity and health policy. And so all 3 of my guests, who I'm getting ready to introduce, I know them from doing that work, and additionally, a couple of them, all 3 of them move in a more mental health space, but one in particular specializes in that, but 2 of them are actually healthcare providers. And so without further ado, and I have to introduce my friend and sister first, Dr. Leah Gordon, who is a doctorate level nurse practitioner, who is going to come and just share all of her knowledge with us about being a practitioner, but also from community, and is a Black woman and understands the plight within Black and brown communities when it comes to health disparities. Next up is also a doctor, Dr. Richard Lee. We call him Rick. I believe it's Rick. Am I doing the form? It is Richard on the birth certificate, but we call him Dr. Rick Lee, and if you leave it to him, you just call him Rick. And he is a great supporter of the platform and also is very knowledgeable in areas of prostate cancer and men's health and just health equity. And really, you'll peep his energy in just a few minutes. And so certainly, last but not least, and not a stranger to this conference, is Keith Maskow of the Triggered Project. He is, I'm going to try to see if I can remember the list from last night, an actor, a producer, an advocate, a Black man, and just a humble brother, and a sneakerhead. Somebody said sneakerhead. I heard that in the back, a sneakerhead. And so please do me a favor and give my esteemed panel a hand, and we're going to get ready to talk about men's health with a little specific focus on prostate cancer. I got to move up a little bit because this is a little different for me. Y'all helping me get my little Jay Leno thingy on. All I need is a desk. And so I'm going to, of course, start with Leah and ask you. On my platform, I often ask my guests to generate conversation to talk about the subject matter by naming it with one word, and then we'll get context. And so, Leah, the status of Black men in health, if you were to name or to give us one word by your observation as a provider, presumably a sister, a daughter, or auntie, cousin of a Black or brown man, how would you describe men's health in one word?
One word for
One
Black
word.
men's health?
Yeah.
Concerning.
Concerning. And we're going to give you an opportunity to do introductions as well, but I want to set some sort of context for our conversation. Rick, well, in this setting, you're going to be Dr. Lee, because we're recording and it's, so shout out to the team up there, George and everybody that's making everything happen. Thank you so much for that. Rick, men's health, and I would ask you a little bit more in relation to coming out of COVID, men's health, particularly prostate cancer, where we are, post-COVID, late screenings, how would you describe that in one word?
I would say advocacy.
Advocacy, okay.
Yep.
Absolutely. And Keith, I want to ask you, in the context of what we learned and saw last night and me knowing you, how would you describe us as Black men in prioritizing our health in one word?
Fearful.
Fearful, okay. So we're going to jump right in. I'm going to give my panelists the opportunity to introduce yourself. Tell us a little bit about yourself, because I think it's important for the audience to know all three of these folks here are personally invested in this space and in this work. So a little bit about you, and then give us the context for your word and remind us of your word, and we're going to do the same thing for all three.
Sure. Hi, my name is Leah Gordon. I'm the Associate Dean for Inclusive Excellence, Diversity, and Belonging here at the School of Nursing at Boston College. I'm also a family nurse practitioner by training, and I'm a nurse practitioner at Mass General Hospital taking care of mostly patients who are men with prostate cancer in radiation oncology. This work is very important to me because I feel that as my role as an educator, really reaching out to students and preparing them to be properly educated and prepared to take care of a diverse patient population is so important. We talk about diversifying the nursing profession, but the population is diversifying faster than the profession is. So really feeling like we need to empower all of our students, specifically our white students, to be very much prepared to take care of our patients with cultural humility. I know we use the word competency, but it's not a word that is my favorite word, but to be humble and to really have curiosity, to want to engage with our patients so that we can really get people to engage with healthcare in a preventative way, prevent these things from happening. So when Keith says fearful, I want to get our nurses out in the world to dispel that fear and to really be able to strongly engage with patients. And I love my nursing practice. I've been a nurse for 20 years, a nurse and a nurse practitioner. It's changed my life, and I really want to instill that in our students.
You're not just going to sneak us on us. You've been doing nursing for 20 years and look all of 20. So 20 years.
20 years.
Wow, Leah, okay. Remind us of your word and then give us some context before we go to Dr. Lee.
Say again?
Your word for men's health. Remind us of the word and then give us the context in which, the reason why you chose that word.
So nursing chose me. I had a very good mentor who encouraged me to become a nurse. And I never thought I'd see myself in oncology. And because nursing is such a vast profession, being part of oncology has really led me to many diagnoses: lung cancer, head and neck cancers, prostate cancer. And all of these cancers, we as a Black community are diagnosed later and unfortunately succumb to these diagnoses. So for me, oftentimes being an only, whether it's in nursing academia or in the healthcare system, I feel that I can serve as sort of a beacon to help our community understand the importance of the health that they need, and that we have these wonderful resources here in Boston that they can access.
Absolutely. I'm going to ask Tech to do me a favor, our AV folks. If we could get just a little more in the monitors so we can hear each other up here, that would be great. Remind us of your word, the word for men's health.
The word I
Yeah.
used was concerning.
Concerning, okay. And you gave us that context there. Thank you for that. It's a good segue into Dr. Lee when you were talking about, coming into or being diagnosed later. Dr. Lee, I posed the question to you, and I think your word was advocacy. A lot of us know that during COVID, hospitals had closed. People were fearful to go outside, and then some were fearful to actually go into the hospital. And so I want to ask you, Rick, you said your word was advocacy. Tell us a little bit about what you do, and then also tell us why you said advocacy, and maybe speak to sort of what you're seeing post-COVID in reference to screenings and where we are with men of color, particularly Black men, when it comes to prostate cancer.
Sure. Well, thanks very much for inviting me to participate. I'm like sinking into this couch. This is like the most comfortable couch ever. I might take a nap. But I'm a medical oncologist at Mass General Hospital. I've been at MGH since 2001. So Leah and I do some work together over time. And so what I focus on, though, in medical oncology is I take care of genitourinary cancers. So that's prostate, kidney, bladder, testicular, penile cancers. Mostly men are in my patient population, but there are some women with bladder and kidney cancers. So what we learned with COVID was really a problem of access, and with that problem of access, it amplified the problem of access for folks who are marginalized. And so one of the things that really made me think about a lot was the really incredible disparity in death rates from prostate cancer in Black compared with white men. It's about double the death rate from prostate cancer in Black men. It's about 60% more diagnoses in Black men compared with white men. It's really a shocking difference that is still true today. You can get onto the SEER government website and track the statistics yourself. The statistics may be getting a little bit better, but it's still double. It's shocking. And so when we started really thinking about our own hospitals reckoning with race in the last 4 years, it really was an opportunity for us to come together and think a lot about what is our role in our community, what is our role in the wider community about advocacy and thinking about how do we change the narrative on getting patients access, getting patients information, getting them the right information. That's what led to me and Leah doing some work together and having a lot more, beyond just work, having a lot more conversations together. And that's actually what led me to the Java with Jimmy platform and really, having this opportunity to speak to, a much wider audience. So newsflash, I'm not Black or brown, I'm Korean. But I think that's really important for us to be thinking about the people who need our care, and that's why I do what I do. That's why I'm enthusiastic about it. Now, why advocacy? For all those reasons that I just mentioned. We have this the words concern and fearful. We have populations of folks who are fearful. That's a concern. Where does that leave us? It leaves us to really reach out, and I said reach out, and I mean outreach, and that's what we're interested in is trying to promote education, information, wellness for people, patients, to be advocates for themselves. And that's what I really want folks to understand in the cancer space, is that you need to be an advocate for yourself. You need to just understand what the statistics are, what the facts are, what you need to be screened for, all of those sorts of things. So that is where the advocacy part comes for me, with the second key piece being access to care.
It's interesting because, and thank y'all, Dr. Lee points to the advocacy, and he has been one of the ones that's advocating with the Java with Jimmy platform to make sure we get this information out. Last year was responsible for getting us some pretty significant funding for our health fair. And Joe, so just a little bit of plug, save the date, May 11th, the third but second annual Joseph Betancourt Health Fair that we're having on May 11th. We don't do those anymore. You don't hear about health fairs like you used to some years ago. So Dr. Lee, thank you for that. Keith, I want to ask you, and you're kind of our resident correlation to understanding that mental health is health and wellness, and so you're sort of our resident person tonight with us. And so I want to ask you to tell us a little bit about what you do for those that weren't here last night, but then also your word was fearful. And I want to ask you, based on what Leah said, based on what Dr. Lee said, and I'm sorry, I really should be saying Dr. Gordon. It's the friendship, so please excuse me. See how we do? See that in conditioning the sort of, I'm automatically Leah, but I'm giving Dr. Lee. So I'm going to check myself, and that's another thing we need to do within the medical industry as well. So Dr. Gordon, you've heard what both Dr. Gordon and Dr. Lee said. And with your own experience, tell us what you do, and with both of those in yours, give us some context to why you said fearful, because that's real.
Yeah, thank you so much. The work I'm doing around Black men's mental health, I run a nonprofit called the Triggered Project. One of our missions is to change how social workers, psychologists, nurses, and now educators learn about Black men and trauma. I'm sharing my own story as a survivor of abuse, and through film, stage and film, with what we showed last night called Triggered Life, and we're using that as a learning tool, which is incredibly important. And we've had some pretty good success in terms of changing how social workers learn about Black men and trauma. And my partner was a social worker, and when I disclosed, felt incredibly lost and a little bit angry, because in school, when she went to Simmons, there was nothing about Black men and trauma. And felt like that shouldn't be, and we put our heads together and we figured out how to do something about it. So a lot of my work is around that. My work is also around helping people find their voice through art, and which I'm very happy to be with. But mental health is health, number one. We do understand systems of care were not created for men, especially not created for Black men, Black and brown men. And so there is a lot of fear there. There is a lot of lost trust historically around healthcare. And so even though there is a little more discussion talking about mental health and talking about health, there is still a fear. And sometimes when we go to get care, we're not sure if folks on the other side really care about what's going to happen to us, or whether or not we're going to receive the same care that somebody else who came in right after, who looks different from us, right? Sometimes those are real experiences. I've listened to my partner, who used to work at Boston Medical Center, was the lead social worker on the weekends, and one thing that she would fight for is for every patient to receive the same care. And that was something that she had to challenge a lot of the social workers and some of the nurses to make sure that that happened. And she was labeled as a troublemaker at certain times because of it, but she didn't care, because everybody that was on methadone mild who would come in and out deserved the same care as someone who came from Beacon Hill. And that's incredible. That's incredible that she did that, but it more says of sometimes the lack of trust. And so it's great to be here with two folks that we know that are trusted and are trying to spread the message that should be spread, that folks do exist. Because I think sometimes we're caught in an old narrative in a lot of ways. And it takes education, discussions like this, and for education to happen in a different way so we can be welcomed into those spaces.
Absolutely. I love when my guests help me line up sort of the next segment or next piece. And so I'm going to start with Dr. Lee, with you in this segment, and ask you what Keith just named and where we are. We're in a post-George Floyd period. We've rectified a lot of our systems. That is what some of the messaging would be from sort of big, the medical industry. Let me ask you, Dr. Lee, very plain. Is the fear, and I'm going to ask you to give some historical context because Keith talked about an old narrative, is the fear that a lot of not just black men, but black and brown folks in general, let's say BIPOC in general, is the fear real? Is it justified? Is it valid? Yes or no?
Absolutely.
Why?
Well, you need to.
I've never seen. I'm
mean-
sorry. I've never seen Dr. Lee kind of get
Here we
stumped
go.
before.
No.
So he's getting ready to tell y'all because I'm going somewhere with the historical
I
context.
need to think about how to frame this. But when you think about the experience that we have, and I've been at Mass General for 23 years, but I've had many examples given to me about patients who have received different levels of care. Now, you can look for why they receive different levels of care, personality differences. Oh, well, it all seems to break down with the color of the skin. Now, this is, a tremendous generalization, and I want to be careful about that. But it is to say that we are still in a learning process, incredibly, in 2024, of how to give culturally sensitive care, no matter the color of your skin, but where you're from and what language you speak and how your culture views health and communication and family. So it's very clear to all of us that the care is not all the same. We are striving for it, and I would say that there are many people on the ground who are really working towards that. I want to believe that there's a brighter day, and I think it's coming. But you're absolutely right that the answer is yes.
There is, and I think you know that I was kind of being a little sarcastic in asking it like that. And so, Dr. Gordon, I'm going to come to you now and ask. Keith talked about it a little bit. Dr. Lee talked about it a little bit. And I'm aware of our conversation that there's a reason why BC sought you out. There is an intentionality. There's a hope that I think that I have as a former program manager of a fellowship program, that in a post-George Floyd, in what COVID exacerbated and saw us, that the trainees that are now coming into medicine are coming in through this, for lack of better words, lack of experience, a woke sort of filter. Are you experiencing a sort of observation of a different approach to looking at folks and to the equity of care of which all of you speak? Where are we in training with this next generation that is coming up in this period of everybody fighting for equity? Where are we?
So I'll speak from a nursing perspective because that's the world that I work in. I will tell you that one of my colleagues who does graduate education, graduate admissions, has said that students are coming to him, prospective students, asking, are you doing the work? Are you doing the work of diversity, equity, inclusion, and belonging? So we have students who are coming at the graduate level and even some at the undergraduate level who are asking for this to be in their curriculum. Now, the good thing for nursing is that we have multitudes of governing bodies who are mandating that we do this work. So one, the ANA, which is our mothership organization, the American Nursing Association, in 2021, after a national commission of consortium of nursing organizations decided to put out a racial reckoning statement, and they are on a journey to make nursing more inclusive, less racist, and more diverse. So this is our mothership organization that's saying we are committed to this work. We have multiple nursing education organizations who are mandating that our curriculum become more inclusive, more diverse. So similar to what Dr. Lee said, I am hopeful that these mandates that are coming from medical as well as nursing associations that govern how we educate will lead us to a healthcare organization, healthcare providers who are more attentive to this concern and paying more attention to who they're taking care of and how they're taking care of them.
Thank you for that. I want to allow Dr. Lee, because we're in this medical training space, and I saw you kind of sit up a little bit when Dr. Gordon was talking. Before we go into the impact as a Black man of what we're addressing with these two, did you want to give any additional commentary, Dr. Lee, of what you're seeing with trainees or this post-George Floyd exacerbation of what COVID showed us in the healthcare industry? Where are we in the near future in the education and training piece?
Well, I do think that we're trying to educate more about what are these disparities that we're seeing. I absolutely think that this is a big part of what we're talking about at major conferences. Plenary session speakers are talking about management and advocacy to eliminate disparities. I guess I'll also say that on our end as educators, I don't think a week goes by when I'm working with residents and fellows, as medicine residents and oncology fellows, that I don't talk about the disparities and actually bring up a set of slides and talk about what are the real key disparities that we're seeing in, for example, Black men and prostate cancer. Because if I don't say it as their supervising physician, then it's not going to be said. And so I think that there's people like us who are actively engaging and trying to make certain that these lessons are taught.
I appreciate that, because there's a reason that we're going here. We have providers, we have social workers, and we're getting ready to get more into the impact of a full sort of demonstration, not demonstration, but a little bit of a story in understanding just one person's example of the impact of either, family history that you shared early on, or just a little bit of what you shared last night, because there is the policy, but then there's the personal that you talk about. We're going to come back with you and talking about treating each patient and each individual. They're your protocols, but we have to treat each one one-on-one, because you never know what, I was getting ready to say the wrong word, what life issues or experience, Dr. Lee knew what I was getting ready to say. You never know what that patient is bringing in the room with them. And so Keith, if you don't mind, if you could share with us a little bit and sort of encapsulate what was shared last night, and then tie in the impact of, and I don't know the full story of when you divulged in the medical end, how a physician or provider's sensitivity to a Black man, period, is really needed in this space.
It's all about relationships, right? And me going to the doctor, being a survivor of sexual abuse, was always something that was difficult for me. But I have to be honest that the last doctor, the doctor that I have now, that I've had for a good while, and so I developed a pretty good relationship with her, and like that's everything, right? Because when I needed to talk about that I was struggling mentally, I could talk to her about it, right? I could talk to her about the work that I'm doing, and that made things a little bit easier. But the fact that I had my partner as well be by my side to help push at certain points when I needed to take my health more seriously was really a pivotal point. But I could see around me there were a lot of men that weren't taking care of themselves, mind, body, and spirit. And that might have been the collateral damage from the other men in my family that had been abused. I think that was one of, that's how it played out in terms of feeling not having the self-worth at a certain point to say that I matter enough, that I need to go to the doctor and take care of myself. But the fear of the unknown, was, has always been something that's there. But my doctor has never asked me about, she's asked me whether or not I feel safe at home, but has never asked me the trauma-informed question. Let me put that trauma-informed. She's never asked me that question. I've never had a doctor ask me any questions. And I'm kind of okay with it.
When you say you're kind of okay with it, I think I need to acknowledge the fact that presumably was some level of a process, and sort of this thing is, and Coach Meg, Dr. Gordon from the Coach Meg at MGH, talked about this term of integration. And so we can talk about that later, but the okay with it-ness, I think often comes for us, and it gets into this term of resilience, and we can talk more about that in a couple of seconds, but I wanted to maybe build upon what you were saying, Keith, and actually start with you in this next round of questions. Is there is the system, there's policy, there are things that fight us when there's this preconceived notion about men that don't want to we don't go to the doctor, and we don't prioritize our health. Is that true? And if it's not, if you could speak, if this room was packed with a bunch of BIPOC, black, brown, young men, older men, what would you say to them about prioritizing their health and you know why I say wellness, their health and wellness? What would you say to them, also in the vein of this sort of traditional, I'm gonna get this right, Western, American, a little bit of urban hood definition of a man? I'm putting a whole lot in there about prioritizing and we're supposed to be the king, and we're strong, and we're, all of this, but we're not generally taking care of ourselves. What would you say to them?
The first thing I would say is define your own manhood. Understand where you learned it from and who you learned it from, and understand that that's their narrative, not yours. That would be the first thing that I would say, because that's incredibly important. I said it last night. All the things that I learned about being a man were all the same things in the way of my healing. And so I had to redefine what those messages were, right? And I had to figure that out, right? And I think that's number one, I would say. Number two, it's spiritual and holistic. I think that's very important as well. Because yes, there's Western medicine, but there's Eastern medicine, right? There is thought of some things of way we can heal ourselves and how to put ourselves, in a better position with the type of food that we eat and the language that we use. And this good brother right here has been talking about that for over 20 years, right? For over 20 years, his brother's been talking about what we put in our bodies, right? And that's incredibly important. And whether or not people were listening, right? Whether or not they were really paying attention, having brothers like that's important because it's being said and we're not listening. We're not necessarily understanding that part of it. That is a choice of what we put in our bodies. Regardless of our resources, right? We can make a choice to have a banana instead of the chips or whatever it is, right? And so I think that's something that's really important. There's always somebody in our community who is telling us these things, but I'm not sure if we're paying attention and listening and understanding the value. So thank you, Ayano. Thank you for that. I just had to say that because I think that's really important. I think also, I would say, is know your worth, right? Figure out all the things in your wellness package, all the things that you can control in terms of your health, right? Whether it's walking, whether it's running, whether it's shooting ball, whatever it is. Find all those things, right? Because those things are in our control to be able to do. And it's important to give agency. It's important that we understand that we have our own autonomy and we decide who we want to be and how we want to show up, right? That self-autonomy is so important, and to empower folks to understand that aspect of it is where I would start. And then, yes, you may have to deal with a doctor, but it's important that you educate yourself as well about what is going on. That self-education about looking things up and reading and that knowledge of self is also important, right? I deal with complications from shingles. I've been dealing with it for over 7 years. I've changed my eating. I've done different things. And having the discussion with my doctor, there were certain points where we kind of disagreed a little bit because I was doing some different research. She went and did the same research, and then we came together. And it worked out. And it was some Eastern, and it was also some Western. I gotta combine because people from around the world have some things figured out more than what is in the U.S.
We're going to come back to a little bit of that when I talked about the wellness. We didn't go too deep into that, but again, I love when guests help me segue, and so I want to go here for a second, Dr. Gordon, and there's two subjects that may be sort of sensitive this evening. One is later on when we talk about prostate cancer in a couple of seconds, we're going to have for a couple of seconds, I don't know if it's come up on the show with you, Dr. Lee, but we want to also name that there is a part of the population that will identify as men but have trans experience, and on the other side there is a population that identify as women and have trans experience, but biologically there still needs to be some looking into that. So that's one subject we're just going to touch on to make sure. The other thing is that when people say partner, and I've had some conversation with Dr. Gordon about, the woman's role, presumably in a heterosexual relationship, and the woman has the influence or the auntie or whatever. So I just want to name both of those things. As we're in this time of equity, we also want to be very intentional about equitable language and considerations when we're talking about men's health. So I just wanted to name that. And so in that vein, I wanted to ask you, when Keith is talking about that relationship with your physician and your doctor, and it's interesting because I believe that about therapists. I often say, getting a therapist is like dating. And it's interesting in the medical space to think about after you go through your medical history and after you get registered and after you all this stuff, I want to switch my primary. And so maybe at some point we can come back to that at a later date. Dr. Gordon, that relationship, as others will watch this and you're at the school and whatever. What is a successful doctor's visit? Developing that good relationship that Keith points to. Maybe in your first visit, what are some things that you would walk out of a room and say, well, damn, they're invested in my wellness and my care? What does that look like?
Yeah, so again, I'll talk about this from a nursing perspective because I am a nurse practitioner. So oftentimes I will see patients.
Hold on for 1 second. I give homage, and I thank you for the homage of what you're doing, physicians and physicians' assistants. I used to work in medicine, and with all due respect to our doctors, a lot of them interns and residents and fellows rotate. Have you ever been in a situation in the hospital where the doctor has the title, but it's really the nurse? That because they do it so often, they know it better. So can we just give our nurses a hand as well? Dr. Gordon, who is the nurse practitioner.
So as a nurse practitioner, oftentimes I will see patients independent of my attending physician. A few things in terms of creating that therapeutic relationship with the patient is, one, you have to work with an attending who is invested in their patients. Because if you go in as a nurse practitioner, they feel some sort of way about their physician, they're going to feel some sort of way about you as well. So I work with a wonderful attending physician, and she's created such a relationship with her patients that when I walk in as a nurse practitioner, they already have trust for me. That's a pretty dynamic thing, and sometimes NPs will say that that's hard. One of the things that I think is really important is that therapeutic relationship and connecting with the patients. One of the things I do is I don't type on a computer while I'm with my patients. I literally have pieces of paper in front of me, and I'm writing my notes and talking to them, looking at them eye to eye. I think that is extremely important that they know that I'm invested more in who they are and what's going on with them than documenting my note for the day. I'll stay at work till 7:30, meet up with Rick for some French fries next door at the Liberty because we've been.
That's early. That's early.
Because we've had a busy clinic and we're documenting all those notes from really spending the time with our patients so that they know that we're invested in them. Another thing that I do, especially in the world of prostate cancer, is one of the things I have to do, because we've treated the prostate with radiation, is I have to feel the prostate. So I have to feel the reduction in the prostate, and that's an invasive part of the exam. That is the digital rectal exam, and so these are men who are sometimes meeting me for the very first time. And what I like to do, and this is the way I educate my students, is I tell them, spend your time with your patient and do this piece last. Of this digital rectal exam, the last part of the visit. Because once you create a therapeutic relationship with a patient, they'll actually let you do a lot to them, but this is an invasive part of an exam for men, all men. So spending the time with my patients, getting to know who they are, talking to them about the side effects of their treatment, managing, the sexual health aspects of their treatment, things like that, so that people know that I'm invested in them is really an important piece to actually do that invasive portion of the exam.
You started off with one thing, and I was going to go to Dr. Lee, but I want to specifically go to Keith right now, if we can, and we're going to transition the conversation into what you talked about a little bit earlier in the trauma. You just mentioned that part of the exam is a digital rectal exam. You talked about sexual abuse. I'm going to keep it 100. Men, particularly black and brown men a lot, but men in general, will not talk about being sexually abused, whether that is in a heterosexual relationship or not relationship, a heterosexual situation, or in a homosexual or same-sex. In this particular case, you were very transparent last night. Can you talk for a minute to providers that will watch this later, and to also give our brothers some level of affirmation, Yo comes out when I'm really getting into a passionate place. My manager's laughing at me. Some affirmation around, first of all, you're not the only one. And second of all, I keep coming back to this again. Western American, if we're supposed to be all of that, then how do we translate the priority of addressing this into fortifying this kingship that we are supposed to walk in? Again, I know you're up for the assignment, a lot in there, but I know you got it. Go.
Give yourself grace.
See, you can't. The one he did earlier, he just came with this wonderful little quick thing. You can go ahead, give yourself grace.
I think, well, no, that's the thing, right? Sometimes us as black men don't give ourselves grace. We only can be who we are. We can't be who someone else tells us to be. That's somebody else's narrative. We've got to live our own narrative and show up for the man that we want to be. See, we all get trained a certain way, right? And I talk about trained too because I'm West Indian and whatever, and I know I was trained here. As a Vision boy, I know I was trained. We all have a point in our life where we have the ability to decide how we want to show up, period, regardless of our backgrounds and whatever. We control how that works. We can go along the tunnel the same way, or we can make a different decision. And so that's the first thing. The second thing, after having grace for ourselves, especially as black men. As being a survivor, talking to folks about that as well, it's part of the truth. The hardest thing is for us to tell ourselves what the truth is. It's not a point of being able to disclose to somebody else. That's the second part. The first thing that has to happen is we have to disclose to ourselves. And then we have to sit with it. And then we have to sit that it happened. And then we have to sit with the fact that family didn't protect us. And what does that mean for us? And what are the other factors that came into play? And then we have to figure out how to forgive ourselves for what happened. And then understand that we're not defined by our mistakes or not defined by what happened to us. But we are defined by our resiliency and how we move forward, right? And that's incredibly important, right? And those are the conversations that we don't have. And those are the conversations that we don't have with each other. And we also don't look at the resiliency that we have, just like I was talking to you, Brother Supreme, about the resiliency. We need to hear more stories of our resiliency, of how we made a mistake and we bounced back and we helped other people and we kept going and we were thriving because we found our purpose through the mistake. We're not hearing enough of those stories. Those stories should be elevated because those stories give us hope. Those stories changes the narrative that is told to us. We have the ability to do that, right? And that's why I give it up to, Dr. Motley for doing this. Because this work and this conference is helping to change the narrative. Change the narrative about healthcare, right? Changing the narrative about what is possible for, black and brown males, 18 to 24 and moving on. This is the conversation, and people need to get on board because, post George Floyd or not, some people act like that never happened.
Keith, thank you. There's so many things, and I often feed off the answers, responses from my guests, and so at some point, I think we're going to come back to the importance of what. I love how two simple things you said were so profound is one, the latest was give yourself grace, and then the first one was define your own manhood. And I'm just going to say the thought I had when I was saying that is we have to really combat narratives and media, because I just, again, said that what you just said was soft. Why does giving ourselves grace and walking in our own manhood come across as being soft? The conditioning of this Western American urban hood. Sorry, I'm having some I'm getting some good stuff out of here myself in real time. And so we're going to transition a little bit. And Dr. Lee, I want to ask you, Keith started this with talking about a relationship. Dr. Gordon talked about what a successful visit looks like. I'm going to talk relationship successful visit versus medical capitalism. Capitalism. Dr. Lee is going to get me after this one because I've been giving him a couple of zingers.
Man, okay.
How does,
all right.
how does a
Medical
patient
capitalism.
empower themselves when, and I used to do it, when you book 3 patients in a 20-minute period, you don't know who's, do y'all still say DINKA, did not keep appointment? How does a patient empower themselves when they get to a point, the relationship sound is starting off well, and they divulge what Keith said, but you got to get to the next appointment?
So I want to get to that, but if I may just comment.
Please.
As I'm just thinking about your answers or your discussion points, defining your own manhood, these are universal things that we should be, telling men, women, that we should be defining. These are things that are certainly true in my community of, Korean Americans, Asian Americans. I mean, there's a culture of stoicism that isn't the, that's not the chest.
I'm very transparent. You used the word that I need to say it again and then spell it.
Stoicism.
Oh, stoicism.
Stoicism.
Like
Being
stoic.
stoic.
Yeah, okay, gotcha.
Right? There's like the chest out, Western, and then there's the stoic Eastern kind of view, right? Which is, everything's fine. You don't stick out. But, when I talk about this with colleagues, it's a shared experience across, people of various stripes, I would say. And I always come back to the idea that I have to define who I'm going to be. I mean, if I followed all my male models, well, guess what? Guess how far silence and rage gets you? Not very far in medicine, right? And it's not a fun life to live. But I can't change the way, the older folks are. I can't change that because I don't know all the trauma that they live through themselves, and it is deep, but they won't even talk about all of it. But I would just say that, it is up to us to do these soft things of giving ourselves grace and thinking about defining our own manhood. It's not soft at all. This is how we define who we are. Medical capitalism, medical capitalism, medical
Watch
capitalism,
the transition.
medical capitalism, medical capitalism. So I think that's a really, the economics of medicine are fully, the counterweight to the idea that we can develop really strong, deep relationships with patients, right? Because we are pressured towards seeing more and more and more patients over time. Less time per patient because you got to fit more patients in. Not necessarily because we need to make more money, the hospital wants to make more money, but because we have a lot of folks who need care. And if I don't see a lot of patients, then there are going to be a bunch of people who don't get care. I would say that, what Leah and I have to do is we have to find the common ground that we have with each patient. To me, the thing that I try to do is while I'm sifting through someone's chart that I'm reading for the very first time, is I try to figure out something about them that's interesting to me that I can connect with, because somehow it's going to come out during the conversation. And with that, there's a recognition that I actually looked deeply into their chart, and I learned that, I don't know, they like iguanas or something. I don't know what it is. But that matters. It doesn't take that much time, but it is really, really important. The problem is, that all that time means
I just said, I was trying to mouth to Dr. Gordon, but that takes time. You're doing research on your patient.
right. It's time. It's time that takes away from my family at times. It's time that, that's why we spend so much time in the hospital.
Yeah.
So it's a key problem for us for how do we balance our own lives and these demands. And I would just say that I love my job. My job is fantastic. I hate the medical capitalism of my job because it's terrible. But I will say that establishing a relationship with patients allows me to sometimes be late for a patient because the person before them needed the time and the care. And for the most part, my patients sometimes they get a little, antsy about it, and sometimes they're like, you're 40 minutes late. But there have been plenty of examples where patients have said to me, look, don't worry about it. If I ever need that time, I know you're going to give me that time. And I think that's the relationship that I need to establish from the very beginning and build upon over time. So medical capitalism, terrible. But patients know it too. And I mean, they know we have time pressure. They are always telling me, I know you're busy, and but I have time. Once I'm in the room with them, that time is theirs. But I think that the way that we fight that medical capitalism is really by having this relationship with the patients that is genuine and deep.
Dr. Lee, thank you for that. And I knew you would, like that term, the medical capitalism, and jump on that.
Stoicism.
Stoicism, okay, you got me back real good. I want to ask you in this next segment, as we get into sort of where we are with Black and brown men's health and men's health, you specialize in the area of prostate cancer. Where are we? According to, you said advocacy, and my first question, post-COVID and screenings and whatnot, where are we as far as, I think I had talked to a medical provider recently, and they were telling me that people are unfortunately coming in now at later stages of things because of missing screenings where 2 years ago it could have been stage 1. Now they're screening and then they're coming in at stage 3 and things. And so where are we? Particularly with prostate cancer and any other updates that you may want to give around men's health. But let's talk a little bit about prostate cancer because that is one that is very dominant and ails us and taking us out of here.
Yeah, so for us as a group, just to understand, prostate cancer is the most common cancer of American men. It's the number 2 cancer killer of American men, of all American men. So it is both common and important. We have a screening test that allows us to sometimes identify the cancer earlier. And so the real key question is, well, if that's true, then why aren't we applying it more? And this is where the advocacy part comes in for a patient himself, or I should also say herself because of the transgender questions, but patients have to be aware of thinking about the screening. Their loved ones. I always point to the family and talk about when I'm at an outreach. I always talk to the family members and say, you're the ones who have to get that guy into the clinic because a lot of men don't show up in the clinic. So where are we? Well, there certainly has been a catch-up of doing screenings, but we're still, I think, far behind. We're far behind in terms of mammograms for breast cancer. I think we're still far behind in terms of colonoscopies. Regionally, there have been different reports that describe that Black folks are further behind than white patients in terms of catching up. And that speaks to the problem of advocacy and access to care. So we've got a long way to go.
Okay. I wanted to ask you, I brought this up a little bit and you kind of touched on it just now, and I want to make sure that we clarify, because in these spaces I want to be intentional. And so I mentioned a few moments ago that you may have a woman who identifies with trans experience. Can we just talk from a biological standpoint that is a screening And though a little bit different, it is still very traumatic because of the invasive exam that you would have to do to that woman to check her prostate. Can you just biologically talk, and then you can jump into around that, and then Keith will ask you maybe in that point to just generally speak to it. It would be a traumatic experience.
I can speak to having patients who are transgender women, born men, but transgender women, who've had prostate cancer and bladder cancer. These are real things. And we actually wrote a paper about transgender prostate cancer because of the importance of in the discussion of saying that healthcare providers need to understand that we have to continue to do the appropriate screening for the organs that exist. I don't want to, for whatever remains. This is a very important part of taking care of people. I don't even say transgender, but just people. They are people. And one of the biggest problems, I think, is that they are a very marginalized part of society, and getting appropriate medical care is a serious challenge. Part of the reason why we wrote this paper was not just to highlight an interesting case, but to advocate for providers to make certain that they're thinking about their patients the right way. I'm going to take that one step further.
Yes.
As an investigator, someone who's written clinical trials, the last clinical trial that I wrote for prostate cancer, you have to write a protocol. You have to write eligibility. And the eligibility, usually number one, is a man age 18 or greater. Number two is diagnosed with adenocarcinoma of the prostate. These are the criteria to say you are potentially eligible to be part of a clinical trial. The last trial I wrote a person over the age of 18. The company threw it back at me and said, this has to say man. And I said, no, it does not. Here's our paper that talked about a transgender patient with prostate cancer. We cannot use these language to exclude appropriate care for patients in clinical trials. We have to be thinking about these things as well. Eventually, I won, but I don't know that this isn't the wave of the future. But it is, I think, an important part of what we can do in the academic world as well by advocating for appropriate inclusion.
The reason I am going here, and Dr. Gordon, I'm going to give it to you and add something else there, and then give it to Keith as far as just to speak to the experience of having to deal with this particular segment right here, is on the other side. Let's say, and I just wanted to also say that I'm saying the woman or man with trans experience because I heard someone from the community say it like that, and ever since then I've been saying it because I heard it from the community. But on the other side, Dr. Gordon, there may be a man that identifies as or has trans experience and may still need to get and pay attention to breast exam minimally, because there may be some men that watch this with that experience, and if we don't want to miss them. Healthcare and health equity for all. Can you just talk to that a teeny bit as well?
Well, one thing I'll say about breast cancer is that
It's not just
for
those that are born, but absolutely. That was in my head, but yes.
Yeah, and in my journey in taking care of patients with various cancers, I have had men who have had breast cancer. So for me, this is again about people and not necessarily about gender or sexual orientation or identity. It's about the person who's in front of me and the screening that they need. So as a family nurse practitioner, which is, I'm trained as a primary care provider, I'm going to be asking my patients, are they doing breast self-exams, whether they're a man or a woman? I'm going to be asking my patients who are born as male, are you doing testicular exams to make sure that they're assessing for testicular cancer? I am going to be asking my patients, have they signed up for their mammogram, or are they getting their PSA screening test for prostate cancer? So I'm looking at the person as a holistic individual and not necessarily thinking about anything really other than who the person is in front of me and what their specific needs are.
Thank you. Keith, I'm going to give this to you, and I'm going to set some context for the past 5 to 7 minutes of this panel. Is we talk about trauma, we talk about equity, we talk about health care for all, and a lot of other subjects that Robert is touching on this week, yesterday, and tomorrow as well. And how do you, I believe, presumably, identify as a heterosexual male. How do we, when we talk about men's health, there is a whole wellness, mental health side to, and let me just say for anyone that watches, no, I'm not trying to push no agenda or nothing like that. I'm trying to make sure we all are healthy. How do we do better, particularly within the Black community, at embracing brothers, period? No matter sexual orientation, no matter, may have a unique ability. Part of the health and wellness of our community as Black men is, I think, Dr. Lee, you talked about it, that coming together in relationships and just, things like that. How do we just get there as kings and princes, no matter what makes up life experience has made up the jewels in our crown?
Well,
Are you gonna come with another quick, soft one? I'm messing with you.
I have to be perfectly honest. I've been called soft a lot for my thoughts and what I think. And I never was insulted by that because I knew who I was. Yep. And, at the end of the experience, that was never said to me again. So let me say that.
If you know Keith, that's why I'm sitting up here laughing. Go ahead, sir.
No, because it's all, to be honest with you, and it's so nice to hear your story, Dr. Lee, because it's about how you show up, right? I'm at Harvard this year, and I'm studying with Dr. Ginwright, and Dr. Ginwright says, it's not about how you handle this situation, it's about who you are in the situation. That dictates how you showed up. And you showed up by taking the time to look in the chart to find that middle ground and meet them with your humanity. That is everything, right? We're talking about care or how we get together. But also, when we talk about kings and everything else, that goes back to the manhood piece, right? And defining what that is, right? But we got to meet each other where we are. There's too much judgment that happens, right? Regardless of what it is, if you have good energy and you're a good person, I'm gonna deal with you. The rest of that stuff doesn't matter. But I chose how I wanted to show up. And that's important for us to talk about, right? And also, we create a lot of anxiety around prostate and that exam and what that means and that part of the body. We've created so much anxiety that is attached to manhood that, of course, we're feeling the way we are about it. I was watching Tyler Perry last week, and they was talking about, man, I don't want to get the test. Oh, you want to get the test? Mm-hmm. And whatever else. And it was all these other stereotypes that went along with it. And I was like, see, that has to change, right? And why does it have to be traumatic? It's about health, right? It's the same thing sometimes when you have to get your scrotum touched. It's the same thing, right? There has to be consent. There has to be, relationship built and whatever. And yes, it is our bodies, but we've been told something that doesn't help us, and it's tied to manhood. It is tied to manhood. And that is, and so it's important that we have these type of conversations about it, because we don't talk about it. The fear is talked about, right? Sometimes sexual violence is talked about and is made jokes of, but it is not that funny. But it paints a picture where we're sometimes not comfortable saying, well, you know what, I need to get my prostate care. You know what? It's not that serious. It takes 2 minutes. It takes 30 seconds and whatever. And what I did with my friends is I explained the process that I went to when I did it, right? And it was funny because my wife was there. And I was looking at her like, really, boo? She was like, I'm right here, shoot. Got you. Got you, right? And like...
Wait, hold on, because I know everybody in the room was wondering. If I'm wondering, they are too. She was in the room. Not prep and not with the stuff you had to take, whatever. She was in the room with you?
Yeah, she was in the room with me. Because, you know why? Because she was supporting me through the situation, and my health is also whose health?
Her health.
Her health.
Yes, sir.
Right? And so if she's getting a mammogram or whatever, you know I'm around. However I need to be there to support her and what she does is the same way that she's supporting me around it. And, you know, we joked about it and stuff, and I joked around with the doctor about it as well. You know what I mean? And thank you for talking about the advocacy part, because I've been getting screened for a long time because it's in my family. And I remember the last time I went to the doctor, and I was like, what you mean you ain't gonna give me the test? I was almost offended. Like, what you mean? What you mean we gonna take, like, how we gonna know? Because for me, I was like, this can save my life. Yeah. This can save my life. My father didn't go, and it came and it took him out. And so we know something that can work. And so we had to have a conversation. I go back and be like, well, you didn't talk to me about this. Yes, I don't mind the blood or whatever, but you know what? I want to make sure. I had no hesitation, even being a survivor and whatever, I had no hesitation because I understood this can save my life. There's no choice.
We're getting ready to, did you? Yes, please,
So
please.
when Dr. Lee and I see our patients, they're already in a position where they have been diagnosed with prostate cancer. So anybody who we encounter who has cancer is already in a very vulnerable situation. What we do is try to create a space where they can fully be vulnerable and know that to be their full self, to be vulnerable, so that we can actually provide the supportive care that they need through this journey. And so there are many men who I take care of with prostate cancer whose partners are in the room when I do the exam. And that is not only a piece of support, but sometimes when I'm talking with them about their sexual health, the partners are there in the room. I think it's important for them to be there in the room. And oftentimes I will hear my patients who deal with things like erectile dysfunction and whatnot, who will say, we've been together for 35 years and we cuddle, we spoon, we hug, we kiss. Those are the ways we show our intimacy to each other. And I think that sometimes when we have these conversations with our patients, they're even surprised that we care and want to know about those aspects. We could certainly say, hey, we can write you a prescription of Viagra, but that's not the point of the conversation. When you hear that people and their partners, these individuals, men mostly, and their partners are going through this journey together, we are really treating a collective team. We're their medical team, and we're treating that family as a team in terms of the journey that they're going through as it relates to their diagnosis and treatment for prostate cancer.
There's just so much in real time. A couple of things that Keith said, and then it's just also refreshing to know that despite of a lot of the inequities and injustices that happen in the medical care system, that we have people like both of you that are in it. We want to allow time for the audience to ask questions, and so what I'm going to do, I'm going to ask all three of you, for you and Keith, obviously you'll be the last, but I'm going to ask all of you, in your perfect world, what does a healthy black man, black and brown man look like?
Glowing.
I'm talking about every aspect. Go ahead, sorry.
Glowing, radiating and glowing.
But how? Go a little bit deeper. Like, what are they experiencing? What is their economic situation? Come on, give me the vision. If it was you got a little brother?
I mean, for me, I feel like a healthy black man, brown man, would be radiating and glowing because they feel confident in the providers
That's what I
who are
want.
taking care of them. They feel confident in the medical advice that has been provided to them, that they also know that they can work in a space with their providers to negotiate. I think Keith was talking about the fact that Western medicine, Eastern medicine, all these practices can come together. I mean, there's very few things I tell our prostate patients not to do. The one thing I tell them not to do is testosterone supplements, because that's just defeating the purpose of the treatment. But if they say, I want to have this kind of a diet, sure. If they say that, this kind of exercise works for them, sure. I want to find those spaces where they feel so confident in the care that's provided and so confident from me as a provider that I'm going to meet them halfway, if not all the way, in their care so that they can be radiant and glowing as they walk in the world.
So you went from describing the status of black men or in the healthcare system. Initially, you had said your first word was concerning, to now you want to see them to be radiant and glowing.
That's my goal. That's my goal as a provider. That's my goal as an educator. So that is my goal.
You all give Dr. Gordon a hand. Come on, y'all can do better now. I know, we're in the big room. Dr. Lee, what does a healthy black man look like for you? And yes, I'm asking you as a self-identified Korean man, but what does a healthy black man look like for you, sir?
I'll take it a slightly different take, and I'm going to say insured and with great medical care. Why do I say that? Because there's still plenty of folks out there who don't have adequate insurance.
In Massachusetts, really?
Even in Massachusetts, adequate medical insurance. And I will speak to this and say that even institutions like ours, there are folks who have the different levels of Mass Health, Medicaid, things like Health Safety Net, which is not insurance that's accepted by our institution. Can they see us? No, they cannot. What are we doing then by talking about being an advocate for your health, having access to excellent health care? Not that they can't get good health care at our other institutions across the city. By no means am I saying denigrating any other health institution. But my own is he limits the folks who can come in through the doors to get care. And why is that? Well, they'll talk about the economics of it and
The reimbursement rate and all
reimbursement
that.
rates. But guess what all that is? Who gets caught with
medical
that?
capitalism and
Structural racism.
at the root of it. Yes, sir. Yes, sir.
That's the root. Medical capitalism, call it what you will. Bean counters, call it what you will. I'll probably get fired tomorrow. It's fine. Just don't air this part of the show. But it's fine. But these are the things that drive me absolutely bananas. Is our stance that we're here for everyone, but we're not here for everyone. And I aim to change that. That's part of the advocacy that we work on within our hospital, as we are advocating for people to be advocates for themselves. We are advocates within the hospital system to try to make these changes happen. It's going to be a long journey, but this is why I describe that well-insured, adequate insurance, and excellent access to care. Meaning, you can have insurance, but if you don't have a primary care doctor, then what good is that insurance? Or if you don't, have, the medical team at your disposal, then what good does that do you? That's what I think would be ideal.
One thing I want to add, though, that Rick and I have worked on in our work together is that, and we've done this at the Joseph Betancourt Health Fair, the first health fair, and other health fairs that we've been part of, is we list all the cancer center phone numbers, BMC, Tufts, BI.
You mean
date of
you
birth.
list another
We
clinic's
put we put on a
information
flyer. We
out of
put on-
MGH? You put somebody
So
else's?
it's an MGH event,
Phone numbers.
MGB event. We list all the phone numbers because we, don't want to seem like we are going to the community to promote ourselves. We are going to promote health. That's what we're promoting. The second is, if you don't have that insurance, we want to make sure that any of the advice or information you hear at the health fairs, that you can still call who you do have access to and say, hey, I heard from a provider at Mass General that I need to do ABC, and I'm going to do that with you at BMC or Beth Israel or Tufts. So we know that there's some blind spots in our organization and other organizations, but we want to make sure that people understand that they're coming and getting information because we care about them, and that they can still take that information to their organizations that will work with them.
Here's another plug, May 11th, the Joseph Betancourt Health Fair. I just remember, do you remember he wrote out a whole medical care plan for somebody on a piece of paper? Do you remember at the health fair somebody gave you their diagnosis? You literally wrote out the thing for them to give to the doctor. You had the little XY thing with the numbers in script, and anyway, so this man lives, he's been with us in 22 and 23 at the health fair, seeing patients. We got a person into healthcare for prostate because the primary care physician told him, remember that he didn't need to get the screening, and he went and got the screening?
Colonoscopy also.
The colonoscopy. So listen, Keith is the second to last person to go. First, before we go to Keith, can we give Dr. Lee a hand for his participation as well? That's a little bit better, y'all. That's a little bit better. Keith, what does, sir, as the resident black man on the panel this evening, what does a healthy black man, sir, look like for you?
That's a lot of pressure.
Oh, now at the end he wants to give no, go ahead, sir.
I mean, to be honest with you, the first thing, it starts with self-care and self-love. I think that's important.
That's our accountability space, and I walked away from him yesterday when he started to inquire. Go ahead, sir.
But that self-love piece is important, and that's key. A healthy mind, a healthy body, and a healthy spirit is everything, and that starts with self-love. It starts there, right? Because when we start with our self-love, then we start to glow, right? I see the glow, right? I see the glow, right? I see the glow. I've seen the glow for a long time, and that's what it starts with. And that is the key to our health, because then that goes to our self-worth, right? Then that goes to us being lifetime learners, not only just about ourselves and our community, right? But whomever we decide to deal with in a relationship, we continue to learn, right? And that is, so I see it. I see the work, right? And that's my hope for everybody, right? That we realize the power that we have within ourselves. It's not about money, power, it's not about any of that, but how can we ignite the power that we have inside of us to start that journey of self-love, which will lead to everything else, and all the other decisions that we need to make, we will make if we love ourselves first. And that is, that's my answer.
That was good. That was good. Y'all give Keith a hand as well. We are getting ready. If you have questions for our panelists, we're going to ask you to go to the mics now so we know who has questions and just have an idea as far as time frame. We have about a half an hour left, and so if you have any questions, please feel free to go to the mic now. While you're doing that or not, I just want to again acknowledge Robert Martley and his team, and Dr. Gordon, who was a part of putting this together. There is another day tomorrow, and I'm sure, and if he didn't plan on it, he can get me later. I'm gonna put him on the spot. But there's another day tomorrow, and he's gonna come and we get ready to close out to give you some details about that. And I think that is, now, does anyone have any questions? Sir, brother.
On what you had said about your wife going in the room with you. So in the field of masculinity, right, with healthcare, the work of Derek Griffith out of George Washington University, when you bring the partner in the room with the man, what happens is the doctor's gonna give certain directives to the man. If he's in the room by himself, the man won't tell his wife. And then he won't follow through with the instructions, right? So what happens is the provider is supposed to ask the man, do you give me permission for your wife to come in the room? Because when the wife come in the room and she get the directions in terms of what he supposed to be eating and stuff like that, when they get home, she the one that put him on that regimen and keep him straight. He won't keep himself straight. The research shows that. So the woman ends up caring for his health and making sure he's in line with what the doctor's order said because she needs him around. That is the purpose of that. So exactly what you said, brother. You know what I mean? And then we need to be in the room when they get in their mammogram. We need to be there for them when they dealing with all of that stuff and be involved. Even though they may not need us as much, the research says, because they got friends that they talk to about that, when you're there with your partner, it gives you points. And then that's something else that you guys could talk about in terms of that reciprocity. But the piece, you educated me today. I never heard the concept of medical capitalism. I never heard of that. And so, and Dr. Rick put it out there, certain kinds of insurance, brother, you're not getting in. You're not gonna get in. And so, but my thing is about these doctors, right? So I'm an educated man. I'm a PhD or whatever. Doctors are disrespectful to me. The same stigmatization that I get, you know, when a white woman grab her purse or when the police look at me funny, when I go to the doctors or my doctor look at me the same way. And they don't talk to me the same way. They don't give me the same audience in terms of what I want to ask questions. I think they kind of look at my questions sort of like stupid or elementary. I don't know. You know what I mean? But the disrespect is still there. You know what I mean? So my question is this, and we talked a little bit, in the same way that we got to interview mental health providers, we got to interview doctors. You know what I'm saying? How, if you ain't been if you're not educated, and you know what I'm saying, and you don't have the words to express that to your doctor, and you only got 10 minutes to develop that rapport. After that, I don't even see my doctor no more. I see a nurse practitioner for the rest of the visits. You understand what I'm saying? It's crazy to me.
Now, wait a minute, no disrespect to nurse practitioner. No,
There's a good one right
I'm
here.
messing.
I mean, y'all probably understand what I'm talking about. I'll go in, and the nurse practitioner be like, yo, you're not seeing the doctor today. I want to see the doctor. No, you're seeing me. If you want to see the doctor, I got to reschedule a couple of weeks back out again. You know what I mean? But once again, medical capitalism. I think there's a godlike complex for doctors and in terms of how they talk to me. If you don't have the words, how you supposed to engage that relationship?
Either one of our providers. We're going to hear from the nurse practitioner first. Go ahead.
I mean, as far as I'm concerned, my job every time I go into a room with a patient is to educate them. That is my role. That is actually one of my favorite things to do as a nurse and a nurse practitioner, is to spend time with my patients and see where the blind spots are, see where the gaps are, and educate them appropriately. And if that takes more than the 20 minutes that I'm allotted to take care of patients, I will spend that time doing that. I have many men who come in, and I can tell that they're not 100% clear on what is going on. It is my job to make sure that I can talk to them at a level that they're going to understand, to help them understand the information. And I mean, I don't want to give myself like a lot of props or kudos, but one of the things I will say is, as a woman of color who walks in the room, I'm not the physician. I'm always in a place of fear that I'm going to be rejected and kicked out. By the end of these visits with these patients who I'm concerned are going to kick me out, they will say to me, I'll always end my visit saying, do you have any questions? And they will usually say to me, you've been so thorough, I do not have any questions. So that's my goal when I go into a room with the patient, is one, for them to accept me as the provider, as an educated provider, and then two, to provide them the information that they need so that they leave that visit feeling as well informed as they could possibly feel.
Dr. Lee, you had anything to add?
Yeah, well, first I would just say I'm horrified that you are disrespected by, other members of our medical profession. That's awful, and I'm sorry that you've experienced this. Unfortunately, I know that that's not rare. And so the only thing that I can do on my end is that when I enter into a room with a patient, is I have to treat them like a family member and think about how am I going to give them the best advice? How am I going to talk with them, even if it's that, crazy uncle or that cousin that I hate? How am I going to, understand what their situation is, and how do I best convey that information to them in a way that will treat them the way that I would want a family member to be treated? Now, that doesn't solve how do we broadly educate people to do that, and unfortunately, these are old habits that people have of making judgments, and stereotypes save time. So I'm just gonna treat people however however the book, judging a book by its cover. I'm gonna treat them like that.
Judging a book by its cover.
I'm twisting it all around. But the best thing that I can try to do to combat that is really just in our role in education is by talking with the residents and the fellows. And sometimes I do learn that there are patients that we treat that are being disrespected or whose questions are being belittled or brushed off. And it's my job to then say, well, let's take a pause here and let's figure out, why are they asking this question? What are they really asking us? And make certain that they're heard. So I apologize for all of us for the way that you've been treated by medical care, but I would hope that there are going to be people who are coming up who are going to treat patients better.
Thank you, Dr. Lee and Dr. Gordon. Go ahead, Keith, and then we're going to get our brother.
That's not the right doctor for you, number one. Number two, we like to of course, capitalism is what we live in, but sometimes we put people on pedestals that they should not be on. And doctors do a great work, but they're people, and that's what we're learning today, right? They're people, and it's important that we treat them as such, and that there's accountability, right, for how people show up or how they don't show up. So, folks who don't, we know how to say what we need to say, but because of the way the hierarchy is, we don't feel that we can say those things, right? I'm sorry, sir, but I don't really like how you're talking to me. Who do I need to talk to?
Hold on. His exact words in the medical industry: may I see your attending? You asked, may I see your attending? And I think that kind of, yes, no? I'm getting the looks from Dr. Gordon and Dr. Lee. Asking to say, may I see your attending? How does that, no?
Yeah.
May I see your attending?
Yes.
That's a very hurtful thing for me to.
I mean, if they're being rude.
Well, mostly because I don't want to feel like I failed somebody. But if a patient wants to see the attending over me, I will get the attending. I mean, that is their right. I have had patients who have been on the phone with me who have said, they've talked to me and I'm saying, you're missing your visit today. And they're like, well, I want to see the doctor. And I'm like, okay, well, that's fine. You can see the doctor. And they're like, I have that right. Yes, you do have that right. And it is just something I need to accept. But I also agree that, sometimes that positionality of the provider and the patient feels like this. And it should not. It really should not.
What I was going to say also is the one thing that we don't know is that there is something called patient relations.
That's right.
patient relations, and that's important that we understand what that is, because when you're not receiving the care that you need, you go to patient relations.
Yep.
And you have a conversation and you tell them exactly what happened, because there is accountability.
Yep.
And a lot of times we don't know that that's a resource. Because if you can't talk to your doctor, that's not the doctor for you. If they're not treating you the way that they should be treating you, that's exactly where you go. And I will guarantee you that will change.
Or you get the new provider.
So the other thing I'm going to say really quickly is I really appreciated your comment, because my wife used to have to be in the room with me when I wasn't taking my own responsibility for my own health. She don't have to be in the room because I'm going to tell her, right? We had a conversation, and that's why she came in, right? And then, of course, doctor asked permission. Always ask permission. So, and here's the other thing. That goes back to defining what your manhood looks like. Because there's certain times when we switch roles, because that's what the situation calls for, right? And so that wasn't an unsafe, vulnerable situation for me, because we had the conversation already, and we talked about it, and we talked about what support looks like for each other, and we talked about how we both learn about manhood, and whether or not that dictated how she wanted me to show up for her, and how I learned about it, and how I needed her to show up for me, or didn't show up for me. So those are important conversations that help with that situation. But first and foremost, I'm responsible for my own health. And that's my job, to support and be with her.
Absolutely. Our next brother, got introduced earlier, so I'm going to try to get it right. Brother Aranio?
Nope, close. My name is Ayano Strickland.
Close, okay.
If I had one word, it would be acknowledgement. And with that, I'd like to acknowledge you, Keith, for sharing our relationship and our connection over these last decades.
Keith said say 20.
20. And I would like to acknowledge both the doctors for your commitment to us as black men and as those of us with prostates. And I would also like to acknowledge that the men in this room are over the age, I'm going to guess, over the age of 30. Am I right or am I wrong? 35? Yeah. So I would like to acknowledge as well that there's an issue with the understanding of health with young people. When I was sitting, I was thinking, I think when I was young and you thought about health, it was like granddad's health is not good. Aunt May's health is not good. It was always an older person's health issue that you acknowledge as a young person without recognizing that health is every breath you take is health. And what else do I want to say? My question then to you is, what do the four of you do to be healthy? What is so being examples on stage, can you verbalize?
You're not going to do me.
Yes, I am. I'm going to verbalize something that you do that would be a token for those watching this video to get them to see Dr. Gordon, Dr. Lee, to support Keith's work, and to have the courage to have those conversations and to share those stories.
This brother is good. All right, so we're going to ask our three panelists what it is, the question posed to the panelists from the audience.
No, he said four of you.
So I'll wrap it up.
One, two.
We'll start with Keith, and then Dr. Lee, and then Dr. Gordon. What do you do to stay healthy, sir?
Dance. That's one thing that's been in my life for a long time, and that's one thing that's important. But quiet time is important. Play ball. go to school and learn, help other people, listen, be around kids, and show up.
And that keeps you healthy. Showing up sometimes is interesting, but I'm going to give all my commentary at the end. Dr. Lee,
I love it.
how do you stay healthy?
Gotta show up.
Wear some wonderful shoes, but go ahead.
Well, I play soccer when I can, and so if you play soccer, you can't not run during the rest of the week. You got to find some of the time, because soccer keeps you honest about how unhealthy you are. So it's not just about playing soccer. You also have to try to stay fit. So for me, and my children know this, that if I get that hour and a half on Saturday morning just to play with a bunch of guys I've been playing with for a long time, it's a mixed bag of all these guys that are sort of in my age category, then I am happy as a clam the rest of the weekend. I'll do whatever the family wants to do the rest of the weekend. And that keeps me centered. But so trying to stay fit, spending time with my family, and listen to music when I can.
Dr. Gordon.
Well, I'm gonna also say dance. I'm a house head. House music is my thing, and definitely like to get out to dance. Live music. I just saw my boy Mr. Lift perform with Thievery Corporation last week, and like seeing live music just gives me a lot of good energy. And then I am a mother to a grown individual, but I am also an auntie to two small, little, cute humans. And so auntie life for me gives me a lot, it fills me up and gives me a lot of joy.
Okay. Brother Robert, did you have a question or wrapping up? Okay. Yes, sir.
You have to, what's your health?
Huh?
You wanna wait till the end to tell you, talk about your health?
Accountability. Accountability.
I'm going to do it at the
Java.
end.
Accountability.
Okay. No, but first I want to thank you all. This was a great panel discussion and got a lot of information and a lot of terminologies that I didn't know either about attending, so that I can ask for an attending, and that's the boss in charge, even though it's a bad thing for the. Can I say that to the actual doctor itself? I can tell the doctor I want to see their attending, or
Or the patient relations, but let me be clear that is specifically in the manner where a patient, if you feel like you're being disrespected, if it's a medical thing, as Dr. Gordon said, sometimes it is interesting, but you also have a right if you want a different sort of opinion. And then the other thing I'll throw in, and I'm not a physician, but if you also are diagnosed with something or a doctor is telling you something, you do also sometimes with insurance, if there isn't a relationship there, and you want a second opinion, you do also have a right to. I think there was one situation where you had told me to tell someone to get a second opinion. So I just said the attending morally if they were being just downright rude, but not just,
Some hospitals call it patient advocacy, patient advocacy department, or patient relations department.
okay. Okay, but my question, and this is probably more to Dr. Lee. So I went to see my doctor, and I was asking him about the prostate exam. So I'm telling him, my wife has been saying, you got to start getting ready for it. You're gonna have to do the exam one day. And I'm like, I'm not doing no exam until they found a different way of doing it. And so when I went to the doctor, and I was telling him about it, he said, so why? What has anyone? What's the history of prostate cancer in your family? Has your grandfather died? I said, no, he died for something else. What about your fathers? No. Anybody, any males in your family that have died from prostate cancer? And I was like, no. And then he said, well, why do you feel you need to take it? And I said, well, because they say, as black men, we're more likely to have prostate cancer. But what he told me, he said, well, let me tell you this. He said the majority of men die with prostate cancer, but not from prostate cancer. So he said that a lot of times when men die, he said, the reason I would tell you to think about getting tested if there was some type of history of it in your family. But he said, you probably will die for something else, but the majority of men, when they do an autopsy, whatever they died from, they probably gonna find some prostate cancer in them as well, but they didn't die from prostate cancer. So I just wanted to know what your thoughts about those words he told me.
Wrong. That's what I would say. Here's why. He's. Here's why. In an earlier era, if you were diagnosed with prostate cancer, then the surgeon would just take it out, and then you'd have maybe incontinence, not be able to control your urine and not have erections anymore, and a lot of difficult consequences. But we live in a different era now with a more nuanced way of taking care of patients, where identifying prostate cancer and categorizing it between the cancer that you might die with but not from and the cancer that you could potentially die from is a lot more clear. So our ability now to distinguish between these different types of cancer, the slow growing versus the potentially fatal, is so much better. And so the recommendations from all of the advocacy groups, the American Urologic Association, the American Cancer Society, National Comprehensive Cancer Network, is for men to be screened with PSA starting at the age of 45. Men with a strong family history, first-degree male relatives, dad, brothers, sons, but most men in this age category don't have sons who are old enough to have prostate cancer. And black men, men of African American ancestry or African ancestry, should be screened starting age 40. Now, this is quite different, right, than 45. And the reason being that the cancer, as I described earlier, for black American patients is diagnosed at a higher rate and has double the fatality of white patients with prostate cancer. So that is why the recommendation is to start screening at age 40, 5 years earlier than for every other American man. So I think that your primary care doctor needs to have a little bit more discussion about the nuances of the way that we manage this disease, or some real education. Even without a history.
They changed that in the last few years, because I wound up being behind.
And I just want to add to that there are guidelines that clinicians, whether you're a nurse practitioner, a physician's assistant, or an MD, there are guidelines that we are advised to go by. But what I do when I educate my students is that these are guidelines. That is it. They're not the staunch rule. They are guidelines. So you have to look at the person in front of you and think about who they are. Are they a man of color? Do they have a family history? Forget what the guidelines say. Do what is right for the individual who is in front of you.
And for the testing, what's the difference between the more evasive test and then because I know there's two types of tests, right? Or there may be three, I don't know. I know there's two, where there's the stool test and then there's the evasive test. Is there a yes, non-invasive, without being too graphic, with folks. But I want to know what's the is there a difference?
So for prostate cancer, there's two things that we can do. One is a PSA, prostate-specific antigen test that can be measured through your blood work, non-invasive. And then if the patient presents with a history that is concerning, or if you're a primary care provider and you've been monitoring the PSA and it's elevating, then you would do a more invasive test, which is called the digital rectal exam, where the posterior portion of the prostate can be felt through putting your finger into the rectum and feeling the prostate.
And I saw 3 of y'all go.
I know, the stool test is colon stuff. Totally different diagnosis, totally different realm than we are in. Yeah, there's a Cologuard that you can do. That's a pill you can swallow, and then it gets put out through your feces, and it'll tell you some information. But that's colon cancer, which is different than prostate cancer.
Colon's 45. That changed a few years ago also. Colonoscopy, age 45. Yep.
And let's be clear, because I know even with the citing of the changes, it's like, wait a minute, y'all said one thing one time and y'all said another. The more the research and the more, and let me park here real quick. When we talk about research, the more we do where there is a relationship, and in specific cases where there are cancer diagnoses, you can ask your doctor about this term called clinical trials. There are some clinical trials that basically mean, and correct me if I'm wrong, that this information is not on the public yet. They're testing it. We heard a lot about clinical trials around the vaccination. That was also where it got on my purview, that we need more Black and brown folks to participate in clinical, trusted with good primary investigators, and you may have to take some research. We need more of us to participate in clinical trials, because that's where you find out if there are any adverse reactions to what makes up our DNA, Black and brown folks of African descent and things like that. And so you'll hear more about that on Your Healthy Java, but it is important that we think about those as well. Clinical trials, and also asking, if you're diagnosed with cancer, having that relationship with your physician to be able to ask, what are some other alternative, mixing again of the Eastern and Western. Was I wrong? Did I miss anything there? I've been doing Your Healthy Java for a couple of years, and so you just get it. We're getting ready to close out. First thing I want to do is thank Robert and Dr. Gordon for the opportunity to do this. Let's give the whole planning committee a hand, please. Thank you to George and everybody in the booth for the technical. Dr. Gordon, please give them a hand.
Yes, I didn't get to say thank you to George for last night, but thank you, George.
And also, let's give him a hand again. Give flowers. Dr. Gordon and also Dr. Gordon and Robert will let you all know this is going to be made available online. I'm going to put it on my platform, Java with Jimmy, shameless plug, at Java with Jimmy on all social media platforms. But we're going to put that on there, and they'll let you know and send an email out when that will be available. What I will do before I close out with what I think I have as a synopsis from what we heard today is, since I've been doing Your Healthy Java, I have become more intentional about hydrating. I don't used to not drink the right amount of water that I should. I have given up Haribo gummies and chips every day with that red number 5 and all that. I'm sure I've given up. It's now fluctuates. Chips are like 2-3 times a week. Gummies are less. Gummies are less. And also, I am very I know that my self-care, I literally need to physically leave Boston. That's the only way I turn my phone off and whatnot. And so I've been more intentional lately about that. And so those are 3 things that I'm doing to try to be more healthy. I got a whole canyon, not room. I got a whole canyon for improvement. And so Keith, here and now, every now and then, he tried to last night and I walked away. I try to be intentional about self-care. I got brothers like him in my team that try to pace me in not being so busy. And I go to Estella's. That's part of my self-care. And so what we heard this evening from our panel is that it is vitally important that we understand, first of all, ourselves as men. We define our manhood. We must give ourselves grace, and we must also make our overall health, which is inclusive of being well in the mental space, maintaining mental wellness. But when we must address our mental illness, we need to do that. We have to be knowledgeable about the medical system and understand that our providers work for us. We pay the insurance, and we also have to, again, make our health a priority, but also understand that it is in a medical capitalist system, but we have tools that can empower us by listening and remembering and going to the video when we post it to what both Dr. Gordon and Dr. Lee said about empowering ourselves and understand in that situation, sir, that relationship with that doctor was not right for you, and you have the right to find yourself a medical team that will care for you equitably, adequately. So please put your hands together for our panel tonight. Thank you all very much. There is some refreshments out in the lobby area, and thank you. And if I could just bother my panelists, if I can get Brother Newt to take a pic, and we can go eat. Oh, Robert, did you want to cover tomorrow? And also, please don't forget, Robert is capturing commentary about this event, so please go see him at the camera back there.
Just a real quick announcement. Tomorrow we have our last day of the event. It's going to be the role of mental health professionals in treating Black and brown emerging adults who have been who've experienced trauma at the hands of police. So we're going to have two panel discussions and a presentation tomorrow